Hello, everybody. Welcome to Grand Rounds. Today, we're thrilled to have with us Dr. Pascale White, who many of you know already. She's an assistant professor of medicine and GI and the director of the Gastroenterology Clinic uptown. She and I have had the pleasure to work closely on C5, the citywide colorectal cancer control collaborative, where she has been focusing on reducing disparities in colorectal cancer screening in African Americans, and that's what she's talking to us about today. Dr. White.
Thank you so much, Dr. Weissman, and everyone here for having me. It's a pleasure to discuss this very important topic, and if there are any questions, obviously you can put it in the chat and we can address them after the talk. I do not have any disclosures. So today, my hope is that you will leave this talk with having a better understanding of the rationale for earlier colorectal cancer screening in African Americans. I want you to be able to recognize the patient-related barriers that African Americans face in obtaining colorectal cancer screening. I want you to be able to identify the physician-related barriers that exist in recommending screening in this population, and also looking at certain interventions available to increase colorectal cancer screening. So colorectal cancer remains the third most commonly diagnosed cancer here in the United States, as well as the third most common cause of death. In 2020, here was estimated that there will be about 147,000 colorectal cancer cases diagnosed and about 53,000 people to succumb to this disease. Now, 80% of colorectal cancers follow the chromosomal instability pathway, where it goes from a normal epithelium, and there are different mutations along the way that occur. Namely, the APC tumor suppressor gene turns those that are early adenomas are formed from that. And then we have the KRAS and SMAD4 mutations turning early adenomas into late adenomas. And then the final insult here is the P53 tumor suppressor gene causing frank carcinoma. So it's known that it can be from 10 years from normal epithelium to frank carcinoma through this pathway. With regards to stages and 5-year survival rates, we know that colorectal cancer is treatable once it is found very early. And so stage 1, but there's about 90% survival for patients who are found in earlier stages. And as it progresses up to stage 4, where you have distant or metastatic disease, the survival rates goes down to 14%. So all of this to say that finding colorectal cancer early definitely saves lives. Here we have a table depicting the relative risks for established colorectal cancer risk factors. And we see here that there are both modifiable and non-modifiable factors. So the top half of this table, we see that those that have a family history of colorectal cancer and a first-degree relative can have a twofold increased risk of having colorectal cancer. And of course, the more relatives you have with this disease, the higher fold increase. Patients who have inflammatory bowel disease also fall into that particular category. Modifiable risk factors, though, are things that I definitely focus on with my patients, namely from heavy alcohol use, obviously obesity is a risk factor, red meat and processed meat, and obviously smoking. So all of these I definitely focus on with my patients, discussing that. And obviously there are things that could be protective, right? There's physical activity that could be protective. And then certain studies that have shown that a certain amount of dairy intake can also be protective as well. So colorectal cancer screening tests, we have an array of available tests available to our patients. And I'd like to break them down from detection tests here in the red and prevention tests in the blue. So when we talk about detection tests, we talk about tests that you can detect in the stool, namely your fecal immunochemical test or your FIT test that you would have your patient do annually that detects human hemoglobin in the stool. We have your hemocholcensis, or your highly sensitive guaiac testing that also can be done annually. And then you have your fecal DNA testing. So it's a mix between a FIT test and stool DNA that can be done every 3 years. Now, needless to say, if any of these tests come back positive, then your patient automatically has to be referred for a diagnostic colonoscopy in order for them to see what was going on. Now, for prevention tests, this is both diagnostic and therapeutic. These are your invasive tests in which you would perform a colonoscopy, and if there are no polyps found, you can do that every 10 years. We have people who opt to do just a flexible sigmoidoscopy, which is only looking at the left side of the colon every 5 years. Couple that with your with stool testing, and also a CT colonography, which is done every 5 years. Now, I'll put the summary of these stool-based tests just so that you can see how good they are at detecting cancers and adenomas. And we have here in the first column your FOBT that has a detection of less than 50% for cancers and even less than 20% for adenomas, but has a high specificity of 95 to 97%. Whereas your FIT and your FIT DNA testings are going to have a higher detection of colorectal cancer and obviously a higher detection of adenomas, and also pretty high specificity as well. For your screening test performance for your invasive tests, we have the colonoscopy, which is 95% sensitive for both cancers and advanced adenomas and very high specificity at 90%. Clearly, the sigmoidoscopy looking at only the left side of the colon is going to have half the sensitivity, but still relatively high specificity. And the CT colonography comes in a little bit less of specificity at 86%. Now, colorectal cancer screening guidelines have been on fire and they've been on the news probably starting since 2018. But even before that, we had the United States Multi-Society Task Force, which is a task force comprised of the 3 major GI societies, that in 2017, they recommended that screening begins at age 50. So in the following year, the American Cancer Society in 2018 said, oh, wait, actually, we want to begin screening at the age of 45. And this was brought about namely because of the increase in early onset colorectal cancer that has been found to be increasing, especially between the ages of 45 and 49. And different modeling analysis showed that there was a moderate benefit in actually screening patients earlier and can increase life years gained within that population. And so they had lowered their screening age at 45 in response to that. And the United States Preventive Services Task Force just a couple of months ago in October said in their draft recommendation that they too will recommend beginning screening at age 45. Now, colorectal cancer screening specifically for African Americans, this was a separate clinical guideline in 2009 created by the Minority Affairs and Cultural Diversity Committee. And they deemed that African Americans are a high-risk group that should be screened earlier than average risk patients, starting at 45 years old. And this guideline was updated by Dr. Williams, myself, and our colleagues that looked at all of the literature addressing this particular mandate and recommendation, but also addressed new topics such as physician-related barriers to screening. So let's go into the rationale. So just some statistics for African Americans. It's in 2019, there were about 44 million African Americans living in the United States, comprising 13% of the US population. Now, they had about 202,000 new cancer cases diagnosed, and about 73,000 deaths were estimated that year. African Americans have the highest death rate and the shortest survival of any racial and ethnic group in the US for most cancers. And so for a group that makes up less than a quarter of the US population, this is definitely alarming. Leading sites of new cancer cases for African Americans here in 2019, colorectal cancer is for them still the 3rd leading cause of cancer and the 3rd leading cause of cancer deaths. Now, looking at the trends in terms of the rationale, we see here in the top half here of this figure, the incidence, and the bottom half is mortality. Now, at one point in time in the 1970s, whites actually had a higher rate or a higher incidence of colorectal cancer compared to Blacks. However, there was a shift here back in 1985 where there was a precipitous drop in incidence for whites, and Blacks actually had relatively high increase and then didn't have a drop off until the mid 2000s. In terms of mortality, again, we can see the same shift. For whites, there was a higher mortality here in the 1970s, and then in the 1980s, there was a shift. And that shift allowed the mortality to drop for whites and kind of increase for Blacks, and didn't see a mortality decrease until, again, the mid 2000s. Now, looking back to see what particularly happened in the 1980s, we know that President Ronald Reagan was diagnosed with colorectal cancer, and there was a sharp but transitory increase in detection tests for colorectal cancer around that time, as in terms of a public health response to having him on the news and having him diagnosed with colon cancer. Not sure how that translates to that, but it was an interesting fact to see that around that time, there was a national figure that was diagnosed with colon cancer. May or may not have had an impact at that point. In terms of 5-year survival for African Americans, we see in this graph, the x-axis is for all stages, local, regional, and distant. And the bar graphs, the colors are, in this particular one is for race. And so African Americans here in the lighter green have the shortest survival for all stages of disease. Now, this is a figure here published by Carruthers looking at colorectal cancer in African Americans. And if you can imagine, the blue line is for whites and the orange line is for African Americans. If we screen, let's say, Caucasians at 50 years of age, the proportion of colorectal cancers found underneath the age of 50 or below the age of the target age is about 5.5%. So you would find more colorectal cancers above the age of 50, which is what we expect. However, if we keep that target age at 50 for African Americans, the proportion of cancers found underneath that target age is double that of whites. It's about 10.5%. And so when you think about decreasing that target age to 45 for African Americans, we see here that they're at par with screening a white patient at 50, meaning the proportion of cancers are a little bit lower at 5%, and the majority are over the age of 45. And this again adds to the rationale of lowering that screening age in order to find cancers earlier and obviously diagnose them. Now, the majority of the rest of this talk is going to be focused on barriers. What are the barriers to screening African Americans? Now, I like to think of this as a three-pronged approach or three-pronged barriers approach. We have the barrier that patients have upon themselves. We have the provider barriers to screening, and we also have the healthcare system barriers that obviously need to be addressed. And so first, let's go into the patient barriers. Now, this is a nice table depicting the major barriers in screening in African Americans. We have the first and foremost is a lack of knowledge. There is an underestimation of the risk of colorectal cancer within the community, or a lack of understanding that screening can prevent the development of cancer. And obviously the lack of general knowledge that colorectal cancer is treatable and what screening tests are available. There is a low perceived need for screening, the belief that screening is only needed if symptoms are present. Now, we know that once symptoms are present, that is no longer a screening colonoscopy or screening test. It's basically a diagnostic colonoscopy that needs to be done. And obviously fear of the test itself, fear of pain, embarrassment, fear of detecting the cancer. And obviously there's a culture of silence regarding cancer that is not spoken about. And one of the facilitators here for completing screening I found very interesting was a physician recommendation, or having that physician support in order to overcome this particular barrier, which we'll discuss further into this talk. And obviously the barrier of fatalism, right? The belief that God, let the God's will be done. If I was supposed to get cancer, I was supposed to get cancer, and that there's no option for treatment or cure of colorectal cancer, which we all know that that's not the case once it's found early. And so looking deeper into these patient barriers, the study done by Green a while ago looked at 100 Black men and women looking at their barriers or perceived barriers for screening, and found that there were knowledge barriers, perceptive barriers, and access barriers. Now, knowledge barriers, they found that 43% thought that there was no cause for colorectal cancer. 40% thought that you couldn't prevent it, and 38% thought that it was usually fatal. Perceptively, they feared a lot. The 47% feared that it would be painful. 33% feared the test itself. And then access, about more than half didn't even know how to schedule. Well, that's on us, right? The physicians need to have the onus on explaining to the patient how to schedule it. And so all of these barriers from knowledge, perceptive, and access hinder our patients from getting screened. Now, the risk perception is another barrier that was looked at in particular studies, and it found that African Americans often have the perception or misperception that their risk of getting colorectal cancer is low, whereas 36% of them thought at one community health center that their risk for getting colorectal cancer was below average, and among those that perceived a risk, they were unaware that they can do anything about it. And so again, it's worth emphasizing that we should inform our African American patients that they may be at an increased risk for colorectal cancer for all the reasons that we discussed in terms of the higher mortality, the lower survival, and obviously the higher incidence. Now, the barrier of fatalism it has two primary beliefs within this particular studies. One is that once the cancer has developed, there are no options for treatment. And 25% believe that colorectal cancer is not curable. 58% believe that they have no control over detecting the cancer early, which is obviously pretty startling because we know that that's not true. And obviously surgery can spread the cancer is one of the other fatalistic beliefs that came out in the Cooper study. And so what do we do here, right? We're looking at the first four barriers, but there are more, right? And this is a barrier that a lot of African Americans do not want to discuss, and that is mistrust. Mistrust of the medical system, mistrust of your physician. That's something that is a big barrier, obviously, because of the previous historical atrocities against African Americans in this country, namely from the Tuskegee study, that have been a major barrier that they don't want to talk about, are being used as guinea pigs, and that fear of having unnecessary procedures is a major barrier. Financial, obviously, the cost of screening and lack of insurance. Patients are often at the mercy of their insurance companies as to what can be covered or what they can do. Even it goes from what kind of prep they can take. And so that is definitely a barrier. And obviously, access is a barrier too. Logistics of scheduling and referral process, the time available or time that you have to take off from work. And clearly there are other screening tests that we can offer these patients in order to overcome that particular access barrier. But it's worth noting that we should be inquiring if that is a barrier and how we can overcome them and help them overcome them as their physician. Now, looking at all of the choices that we had, it was interesting, to ask the question, will giving patients a choice impact adherence? And I am pretty sure that at that point in time in history, President Obama was thinking of, what kind of screening test am I going to have for colon cancer? And President Obama was very intuitive and he was very smart, and he did not want to relinquish his presidential powers in order to be sedated for the test. So he actually chose a CT colonography. And I want to go on record that I would welcome President Obama to have his next screening test with us here at Sinai. But essentially, will giving patients a choice impact adherence? And it was found here in Anna Domi's paper here that it does not. So giving choices does not equal less adherence. So if you had the patients, for example, had a FOBT arm and you told them you have to just get an FOBT and that was the recommended test, versus telling them just get a colonoscopy and that was the recommended test, versus giving them a choice, we found that giving them a choice actually was better than just telling them to go get a colonoscopy, or actually just telling them to get an FOBT was better than just telling them to get a colonoscopy. So it didn't impact adherence. And oddly enough, there were racial differences within this particular study. So here in African Americans, we find that if given a choice, they would choose to have an FOBT completed, which was the opposite for whites in the study, where if given a choice, the majority of them would complete a colonoscopy. Now, this is important in that if we know, or if there are more studies looking at whether or not we can give our patients these choices and know which ones they would take, then we would obviously help and support them to continue doing that screening test. So if we know that our African-American patients want to be screened better with a stool-based test, we have to make sure that it is done every single year, annually. One and done is not what it is about when we come for colorectal cancer screening. So we have to understand that it's an annual choice that they are making. Now, again, another study looking at racial differences in screening modalities, we found that for any test, whites were going to complete any test more than African Americans and Hispanics in this study. But looking at FOBT, African Americans actually had a higher completion rate than whites. But when you're looking at those who were going to colonoscopy, whites had a higher completion rate for that. So again, different studies showing that there may be a lean towards having more non-invasive tests in this group versus others. Now, within this same study, we found that being current with colorectal cancer screening was strongly associated with having a regular doctor, annual exams, and a doctor recommendation. And minorities in this study actually reported a lower rate of doctor recommendation for screening, which begged the question, well, why would they be reporting that? So let's go into the provider barriers that are driving racial disparities in colorectal cancer screening in African Americans. So provider barrier can be seen again in the same form of knowledge, perception, and access. And I beg the question of knowledge barriers to be in the form of guidelines. We just saw that there were definite guideline changes within the past 3 years. There are different societies reporting different types of recommendations of when to screen and what to screen with. And so it's kind of hard to keep up with those guidelines. We get it, but that's obviously a barrier that we should be aware of and that we should address. Perceptively, we have the lack of recommendation. And we have to ask ourselves, why are providers not recommending colorectal cancer screening within this population? Is it conscious bias, unconscious bias? Is it racism? We have to do more digging on that too. In access barriers, clearly there's insurance coverage. We don't want to strap our patients with bigger bills. And so we have to make sure that their insurance covers a particular screening test. There's a time management factor, again, looking at the fact that there's a lot of things to discuss during a visit, and do prevention tests take a back seat to all the chronic illnesses that you have to get through during that clinic time? And your EMR system, whether or not their reminder systems are also physician barriers. So digging into it a little bit closely in terms of knowledge barriers for physicians, this was a study done by a questionnaire at Sinai, looking at the knowledge scores for medical students, residents, and internal medicine attendings. And this was based on the ACS guidelines at that time. And so general colorectal cancer screening facts, we saw that medical students answered correctly 31% of the time, residents 38% of the time, and attendings 42% of the time. In terms of ACS guideline knowledge for average risk patients, not even high risk patients, medical students answered 32% of the time correctly, residents 49%, and attendings 56%. And when we got to high risk patients, there were fewer than half that had correct answers. And so what was found here is that knowledge barriers existed among healthcare professionals working in a low income, predominantly minority community. So again, not having that knowledge base can impact obviously screening rates. This particular study that was done by myself and my colleagues at NYU, looking at high-risk populations and taking a national survey of physicians. So we wanted to know essentially what were the knowledge barriers in family physicians, internal medicine physicians, and gastroenterologists. And so it was an AMA database. It was an anonymous 19-item survey sent randomly to 25,000 internists, family medicine docs and GI docs, looking at screening guidelines specifically at ACS and the United States Multi-Society Task Force guidelines. And it was a stratified sampling strategy where we looked at the doctors coming from a low incidence state versus moderate incidence and high incidence, just to see if that would make a difference in regards to their knowledge. In looking at knowledge scores by specialty, we see that family physicians and internists scored about the same, about 31%, 34%, and gastroenterologists only had a 50% score. Now, most shockingly, because this is what we do every single day, having a 50% knowledge scores for high-risk patients was definitely a shock. But looking at the results specifically, we see that 92% correctly identified age 50 as the point of initiation for, let's say, an average risk Asian patient, right? But only 28% of all of the physicians correctly identified 45 as the ACG recommended initiation point for African American patients. And Black physicians were the subgroup more likely to correctly identify the screening age for African American patients compared to their peers, 66% to 27%. Now, barriers that were identified within the study, we had 43% report barriers, and of those, 72% had 2 or more. So we see things like patient refusal, we see lack of insurance reimbursement for the early colonoscopy referral, or even patient anxiety, but close to a quarter of physician barriers that were cited were because they were unaware of the current guidelines. That is something that is in direct control of the physician, obviously. And then we have the lack of evidence to support the efficacy for earlier screening, again, namely looking at the data to support that at that time, and then the time constraints on taking full family history was also noted. And so looking at the fact that if you do know the guidelines, clearly, how could you recommend it? So that's one particular barrier. But in general, a physician recommendation for colorectal cancer screening emerged as a key theme in some studies, and showing that provider recommendation leads to increased compliance. And one study even showed that African Americans who received a recommendation from their physician were nearly 6 times more likely to be adherent for screening. African Americans also were just as likely as their white counterparts to get a physician recommendation to get a FOBT. However, they were less likely to get a recommendation for endoscopy versus their white counterparts. 33% of African Americans within this study didn't remember ever receiving a recommendation for any test at all. And they were a third less likely to receive a physician's recommendation for screening overall. And this has been a growing theme in the literature. Looking at the patient factors associated with non-recommendation by their physician, they found that patients who had a lower education, had more than 3 children, had a shorter duration in the US, had an income below poverty level, who were unemployed or had no health care, were all factors that played into not being recommended by their physician. Now, Ali, within this particular Coleman study, insurance status was not a significant predictor of whether or not a physician would recommend screening. However, if there was less income reported by the patient, they were less likely to be recommended. But if patients had more education or more physician visits, they were more likely to be recommended in this study. So we looked at patient factors. We looked at provider factors or barriers for screening, and now we have the healthcare system at its base, at its foundation. And we all know that the healthcare system is imperfect and has its own reasons and barriers for screening, and namely inconsistent access to primary care, or the lack of coverage for colonoscopies, or health insurance premiums that play a definite role in the reasons why that is kind of like at that top barrier, where if patients are on board and providers are on board, we need the healthcare system to also get on board to break down their barriers. Now, indulge me, if you will, looking at this beautiful green forest, okay? And imagine each of these trees are your patients. And it would seem as though each patient in this vast forest has the same access to all of the things that it needs to succeed. It has light, it would have rain, it's obviously in the soil. And so looking at this bird's eye view of the forest, we need to take a little bit of a different approach to look at the patients. And so when we go down a little bit further, a little bit closer, we see that they still look green. We're taking that walk in that forest, we're taking a walk in that patient's shoes, and we're looking at the fact that, oh, okay, there may be individual patients within this forest, within this vast healthcare system that are not doing so well, that are essentially struggling, that would seemingly have the same access to screening and prevention and treatment as everyone else, but they actually don't. And so what makes it that patients, the majority of whom come from low income and impoverished communities, less likely to make it? Well, I would gather, and there is evidence that systemic racism at the root of it, and has been and continues to be the driver of health disparities in the African American community. It is the way in which society continues to foster racial discrimination through inequitable systems that mutually reinforce each other, whether it is through finance systems, education, housing, criminal justice, and yes, even our own healthcare system. Thus, if this is the foundation or soil, so to speak, of this tree of our patient, the social determinants of health, okay, it leaps into there, and it manifests itself within this complex circumstance or environment that the individuals find themselves living in. So whether it be low education, low income, food insecurities, poor housing, poor healthcare access, or high crime or segregation, this is the grass. This is the environment that sometimes we see from our patients and sometimes we don't see. But what we always see are the leaves of the tree. We see the diabetes, the heart disease, the obesity, the cancers, the hypertension. And I ask all of us to look at this bird's eye view with an eye of caution, that each of our patients are coming to us with special circumstances that may have been within their control, or obviously the root causes that are out of their control. So what are the interventions? So we can also look at this in a three-pronged approach in terms of patients, communities, and healthcare professionals. And if we go with communities first, and we see that, we can go into the community, we can do outreach, and we can have these talks to the community, there have been shown to have higher intentions to screen among those who attend these outreach programs, and more positive beliefs about what they can do about colorectal cancer. But there's a disconnect between that belief and intention and actual compliance, which hasn't been shown to be significantly higher after these outreach programs are done in its own silo, right? Not taking into account anything else. And so if we only look at patients, and when we say, well, we're going to reach out to the individual patient, we're going to have them, know all the things they need to know about colorectal cancer screening. Yes, they can be and look at, have 4 times higher completion rate of fecal occult blood testing in certain studies, but the absolute rate of screening came out to be about, let's say, 27% in one study. So just looking at patients themselves and doing that approach or that intervention with just them and not incorporating anything else is not going to have a lasting benefit. Well, how about interventions for the healthcare professionals, right? We know that we have these barriers. What can we do? Well, there's some that showed that monthly lectures and weekly morning reports had a 42% increase in flex SIGs at one particular study in hospital. However, the absolute number of patient screens were only 71. And you can have an increase in resident physician endoscopic referrals after these didactic sessions, and then, or endoscopic observations. But again, that in and of itself is not going to particularly help. All of these things need to be taken into account, patients, community, and healthcare professionals, in order to increase colorectal cancer screening within the community. And now, what if our patients are not coming to us? Do we go to them, right? So this was a beautiful trial by Joe Ravenel here at NYU, looking at, and we called it the Mr. B trial. So it's a randomized trial with about 700 self-identified Black men recruited at barbershops, right, for over 3 years in New York City, recruited at barbershops. They had to be 50 years of older, not up to date on screening. They had to have uncontrolled blood pressure problems and have a working telephone. That's it. And then they wanted to assess completion of colorectal cancer screening at 6 months. And what was the intervention? So they looked at those who were navigated. So the patient navigator helped schedule colonoscopies, or they helped make sure that the FIT test was mailed and that they received it and submitted. And then you had another group that just received motivational interviewing for their uncontrolled blood pressure. And then the third group had both the patient navigation piece and the motivational interviewing for their blood pressure. And what was found was that the group that was navigated had a higher percentage of actually completing screening versus those that didn't receive navigation. So we know that patient navigation works. We know that Alina Jandorf and her colleagues there here at Sinai have shown that patient navigation definitely works, especially when it's tailored to patients. But again, not having that patient navigation piece and just having the motivational interviewing piece, we have to put it together somehow. And that patient navigation should be something that we invest in order, because it does make a difference, especially here in this particular study for Black men, and reaching out to patients in their trusted communities. Patients may not be coming to clinic, but we can and should be making an effort to go to them, because as it's shown here, it can work to increase colorectal cancer screening uptake. Now, the approaches to increase screening, there should be multiple strategies employed to deliver the intervention. You want to tailor the specific intervention to address identified barriers, which takes talking to your patient and knowing what their barriers are. You want to personalize the educational materials and have a culturally sensitive approach to that. Recruit in familiar community settings, these trusted settings where patients go to, either barbershops, churches, beauty salons, and you want to educate the healthcare providers, obviously. But what's unknown is what is the most crucial to be addressed. Should we address just the patients, the community? I would beg to say that all of them are critical in order to ensure the success of the intervention. Now, this is one of the last slides I will show, but it's a very busy slide, but all this to say that Carruthers looked at the framework for colorectal cancer disparities and how we have to interlink all of these strategies together in order to increase health equity and obviously cancer screenings. So here in the a boxed out red here is looking at the federal level, federal payers and guideline groups and public and private partnerships in order to enhance capacity for screening, integrate a screening continuum with guidelines, and promote health information sharing. At the healthcare community level, we will need to look at how we are providing this within our clinics, how we are implementing it within our workflows, and how we're centralizing this in order to nudge the patient to get this test done. And then obviously the community level strategies where you're having community outreach and you're assessing your resources within the community in order to be able to provide these preventive services for patients in these high-risk places. And so this was a beautiful graph, and Dr. Weissman, I didn't have the updated one, but this was a beautiful graph of what C5 did here in New York City. C5 essentially eliminated screening disparities in New York City, starting from less than 42% that were screened, and by ethnic and backgrounds here, white, Black, Hispanic, and Asian, we found that they were obviously screening less than the national average at that time. And by the time it was in 2007 was reached, that they had eliminated screening disparities among white, Blacks, and Hispanics. And that was done because they approached the situation as was discussed: patient level, community level, and healthcare resource level. So it was a full-fledged effort from stakeholders and from patients who themselves were reaching out to us, letting us know what it is that their community needs in order to address their screening disparities and in order to increase screening within each of these ethnic backgrounds. And so it can be done. We've shown that it can be done, and it should be replicated and hopefully sustained going along in the future, even here in New York City, and obviously other cities like LA who have tried to take on similar approaches to what we did here in New York City. So in summary, colorectal cancer disparities exist in incidence, mortality, and survival. And obviously it is persisting here in the African-American community. There's a lack of knowledge, there's fear, there's mistrust, there's access issues, as major patient barriers, and physician barriers exist too. The lack of knowledge of the screening guidelines and keeping up with them. And most importantly, if nothing leaves, if you don't leave any here with this talk with anything to think about, the lack of recommendation for colorectal cancer screening is a major barrier. Recommend colorectal cancer screening to your patients, because again, within this particular community, they're 6 times more likely to be adherent. And obviously, overcoming the disparity gap is not beyond our grasp, but we all must do our part in reaching toward the common goal of breaking down the barriers to colorectal cancer screening. And I'll stop here for questions.
Excellent. Pascale, thank you so much. That was fascinating as always. We'll open up the floor for questions, either by unmuting yourself or typing them in the chat. Maybe while we're waiting for the first question, I can ask you a little bit about, we're waiting for the USPSTF to finalize their guidelines. New York City, obviously, released our own guidelines advocating for 45 and up. I wanted to get your sense of whether you've been able to implement the 45 and up for everybody, and whether you've hit barriers, insurance barriers or otherwise. And then maybe to tack on part C to that question, how you decide for people who are going for stool testing, how do you think about FIT versus FIT DNA?
Sure. So I haven't run into a lot of barriers. I have to say that when I have an African-American patient that comes in and they're above the age of 45, I haven't had an insurance company deny that colonoscopy. And I think now it's probably going to be even easier for that particular population to get approved if there were any barriers for anyone else. But I personally have not, at Sinai, I have encountered that. I think the only barrier that I have encountered so far is like the prep barrier, like I was discussing. Like there's sometimes they're very particular about go lightly versus Miralax or whatever it is. It's just like very, very minor, but I have not encountered those barriers. And I do definitely talk to my patients about the stool DNA testing in the FIT. I do think that it's attractive to them to have it done every 3 years. I do see that, it has a very, obviously the specificity and sensitivity are great. And so I do push the Cologuard because, again, once we order it at Sinai, it goes directly to their house. And it's like pretty seamless. They deliver it and they can pick it up and from the patient instead of the patient coming in and dropping off their FIT. So I do tend to lean towards going to FIT DNA more than just the FIT alone.
Great. What other questions are out there? Pascale, looks like there's a question in the chat.
Can I read it out loud?
Yes. So thanks so much for this talk. Do you know if we refer our patients for colon cancer screening and they're interested in colonoscopy, if their first appointment with a gastroenterologist should be telemedicine?
Question. I always like, not that, obviously with COVID, there's direct referral access or direct access to screening modalities, right? So as a primary care physician or internal medicine resident, you can just send your patient in for colonoscopy. They don't need to see us. However, there are nurses in the background looking at the patient's history. So if they have any anticoagulation history, if they have any history of any anemia, they're screening these direct access patients in order to either get an appointment with us or they can go straight to getting their screening. And so they don't necessarily have to be seen via telemedicine or with us. There is a way for you to decide to send your patient for screening, and most of them do go directly. But if they do have any other medical problems that may need for us to kind of investigate with other things like an endoscopy, for example, if they're anemic, these are people that you should just have us consult on so that we can see them via telemedicine or in person.
What other questions? Anjali.
Hey, Pascale.
Hi.
How are you? We were residents together.
Yes.
Good to see you. Such a great talk.
Thank you.
I had a sort of kind of non-medical question almost, but I've noticed that since the death of Chadwick Boseman, there's been sort of this increased awareness, and a lot of doctors that I see on some of my Facebook or Twitter groups, they're talking about how patients have been coming in actually asking for screening since that happened. Have you noticed that? And what role do you think, the media has in advocacy?
That's a fantastic question. I have definitely noticed an uptick in patients who are coming in with their symptoms, right? So we know that with early onset colorectal cancer, a lot of the younger patients, they're getting diagnosed later, or like when their symptoms, let's say, have been going on for months and months and months, versus patients who are older, who are coming in and getting seen within weeks or whatever of their symptoms. So younger patients were waiting longer, and I finally see that a lot of younger patients are coming in with their symptoms, saying, "Hey, I'm having rectal bleeding. I'm not going to assume it's hemorrhoids anymore. Can we can we do something about it?" So I've most definitely seen an uptick. I think with the increase in the guidelines now, we're going to see a lot of people who don't have any symptoms and who want to come in, right? So without knowing Chadwick's history, without knowing why, it definitely was a shock within the African American community that, wow, this seemingly healthy person can just vanish and just be gone from something that is obviously preventable, treatable, and beatable. And so I always advocate to my patients who come in, don't be afraid to say if you have any symptoms. And obviously with USPSTF, the ACS, obviously C5 here in New York City recommending 45, we're going to see a lot of people who don't have symptoms coming in to get screened. And we're going to see people who see like they just need a diagnostic colonoscopy because they're having symptoms that they don't want to assume can just be something benign anymore. So I've seen that in my practice for sure.
I have a question. Very nice to meet you. Great talk.
Thank you.
So I once got a grant and we had a navigator that we, from the Department of Health, put on the inpatient service. And what I found was most of the staff hadn't gotten screened. We that year got 1,000 staff members screened. So it was a great model. And that became embedded into the GI suite, because a lot of the rigmarole around referring first to GI and then going back to set up another appointment, that delay of whatever that delay was, deterred patients from going. So we know the navigator model works, and we know it's really easy, and we can embed them into all practices and just get them scheduled for colonoscopy just through a navigator. So why aren't we doing a lot more of that?
That's a fantastic question. I think, like you said, you got a grant for that, right? Yeah.
It was a small grant, and literally I just went to the Department of Health because I said we did a simple project through the residents, by the way, and this should encourage residents. We noticed, we just did a survey of all the patients that were admitted and found out if they had their breast, screening, like mammos, pap smears, and colonoscopies. And most of them had not had colonoscopies. So we went to the DOH, we met with the head of cancer prevention. We said, this is what we have as an idea. She gave us $40,000 for a navigator. We embedded it, and that was the discovery. It was hard to link sick patients because they still, variably would show up, but the staff were like, yeah, I need one. We were trying to engage the staff to talk about it with the patients, but they were the ones that actually hadn't screened.
So I think it goes down to what I was thinking. One is like money, right? So the sustainability of having a navigator and having the system invest in placing these navigators within these different specialties in order to have that done. So that's my first thought. And the second was we need a programmatic effort. So here at Sinai, they're trying to work on having just like one base, one single place where every patient can go, whether it's your union or whether it's whatever it is, that Sinai has this colon cancer screening kind of network or program where you can go in and it could be seamless. Has that happened yet? No, I know that they're working on it now because I was part of thinking about it. But I think all comes down to money. And if we can find, obviously patient navigation works, but it hasn't been something that the system has essentially invested in system-wide. I think there are little grants here and there. Obviously, Lena Jandorf and Steve Iskowitz has shown that patient navigation works in the GI clinics. And they've actually gotten a lot better at putting these patients in the clinics. In the IMA, for example, there's a full-time patient navigator that calls patients at night, right? So some patients can't be reached during the day because they're working. So they're thinking about it. But I think there has to be a big lift effort to kind of have one seamless place everyone can go, because there's way too many choices and way too many places they can go for the screening, and it's overwhelming to patients. But you have to put the money into it.
Even
Can I just add too?
Telehealth, even I was thinking, since so many people are like furloughed or so many people working from home, you don't need to actually have a physical person in the clinic. Everything is remote. It could just be a telemedicine, supported service.
Absolutely.
So I was going to add two things to that. I think it's a great point, and I didn't realize we have you to thank for the navigation we've got, Dahlia. So thank you. There is a navigator in the GI practice who helps facilitate folks getting their colonoscopies, direct colonoscopy referral. Cologuard, which is FitDNA, does have a pretty good program. I mean, as much as I love primary care, theoretically, you don't need a primary care doctor. You can do a telemedicine visit on the Cologuard website, and then the Cologuard gets UPS to your house and you send it back. I still think people should go see their primary care doctors, but for people who just want to test, our insurance, the UMR, covers Cologuard down to age 45 for everybody. And people should take advantage of that. And they don't need to see a primary care doctor. They don't need to see GI. They should get screened, and maybe some of this is finding ways to promote that.
Does the website actually stop them if they're having any symptoms?
Yes, I think the website does, and I think the telemedicine visit is to screen out for people with symptoms, because obviously those people need to go get taken care of. And I think, I feel like I'm always saying that at meetings that Chadwick Boseman would not have gotten picked up on this screening because he was 39 or whatever when he got diagnosed. People with symptoms need to go see a gastroenterologist and get all the stuff we used to blow off, that they need to go see Pascale and get taken care of. That's a different story. But there is totally the ability for us to get employees or people who are sort of peripherally connected to Cologuard, to primary care, to GI. The other question I was going to ask, maybe you and Dahlia, is around inpatient care. Like, it seems like, it's hard to get a colonoscopy on an inpatient, but it seems like it would be relatively easy to connect someone to FitDNA after they go home, which, to your point, like FitDNA comes with, or Cologuard comes with, a sort of built-in navigation system. They call you, they send letters to your house, they make sure you send it back. Mm-hmm. Should we be exploring that on the inpatient side in some way for average risk patients?
When you talk about they're admitted for other particular problems.
Yeah, somebody comes in with pneumonia and they don't have a good primary care relationship or whatever, is there something we should be doing with that?
I mean, I think
follow those results, I'm wondering, because that's one concern. You really do need to connect to a PCP. That's one limitation from the hospital discharge.
And I think also with in terms of hospital discharge itself, if you're not being discharged, let's say for a GI problem, how likely are you going to be able to follow up on these patients who come back with a positive Cologuard? So you're leaving it with these patients, and obviously Cologuard is going to inform them, but there has to be that connect with a provider, and the inpatient provider may not be their outpatient provider. And so there goes that twist in thinking about, if you're going to do it from the inpatient side, there needs to be someone to catch these patients on the outpatient world, especially when they come back positive, to funnel them seamlessly through the GI clinic and to see us.
Is there a reason these aren't just done inpatient? To follow up on this idea, Dr. Weissman and Dr. Risk, is there a reason other than payment? And to me, these seem like relatively low cost items on bulk, but I don't know the current payment structure, because then we get into what is actual cost versus receipt and charges. But the actual cost of these, meaning if they only cost $3 to obtain, but we charge people $100 for them, the real cost is $3. Is there a reason not to do this from a public health standpoint? Because people that get admitted for pneumonia don't stay in the hospital for a day, for the most part. On my service, some, but for the most part, they stay for several days, more than enough time. The catch issue is the same one that we have with everything, but this could, again, along the lines of leading to a direct referral. There's no reason for them to have anything beyond a phone call and instructions on how to prep and a place to go.
I think it puts a lot of burden on the inpatient teams and so we know the hospital gets paid on a DRG system based on the diagnosis, and anything additional that you do ends up being at a cost. So they're very focused in terms of the treatment plans for the admitting diagnosis. And then I guess you could talk about every single thing. Do you want to do a CT to look for a pulmonary nodule? Do you want to make sure they get their I mean, at some point you have to make sure that they have a PCP that's plugging them into all that stuff. But it's a great idea for a project if you're really committed and championing it. So it is something to think
All right, what other questions are out there? Nothing. Pascale, you did it. Thank you so much. I think we've got a real call to action to make sure we're screening wisely. Thank you so much for joining us. Thank you everybody for joining us.
So much.
Have a great afternoon.